orchestrated symphony, which is the strength of Universiti Kebangsaan Malaysia. Yep. I would like to introduce our champion for today. Is Dr. Siti Hakimah. She graduated from Alexandria, Egypt. And he did an housemanship in Selayang, and then she did a formative MO-ship in Sandakan, and currently she is final year registrar in UKM. She will be given the task to give the appropriate diagnosis and differential diagnosis to our case, which is a lot, and to formulate a reasonable management of the patient. She will be led by my colleague, Dr. Beh, who is the most hardworking cardiologist in UKM. And also our panel of experts. Let me introduce first and foremost Professor Tan Hujan, Professor of Neurology, Professor Patrick, Professor of Internal Medicine, Professor Rohana, our obstetric and gynecologist, Mr. Hisham, the most handsome CTC surgeon, and also Dr. Tang. So Dr. Tang will be replacing my colleague, Dr. Faizal, because Dr. Faizal is unwell. Without further ado, Dr. Beh and Dr. Hakimah, the floor is yours.
Good morning, everyone. My name is Beh. So thank you for coming to this CPC. So we have actually involved multidisciplinary team in this case. But because of the time, I need to limit the number of panels for discussion. So some of the team are not invited, even though they are involved in this case management. So this is our list of the topics we're going to go through. So these are the abstract that are given to Dr. Hakimah. So the title will be Tackle the Dew in My Heart versus Love in My Womb. So it's a young lady who is pregnant, presented with fever and fitting episodes. She is a 30 years old lady, G2 para 0+1 at 27 weeks. She presented with fever for 3 days, associated with productive cough and reduced oral intake. For her past medical history, she has frontal lobe epilepsy diagnosed at 12 years old, followed under our PITS initially, and then subsequently transferred to our neuromedical clinic. She was recently discharged from the ward for status epilepticus, treated for meningoencephalitis in the ICU for 3 weeks. Clinically, when she arrived, GCS was full. She's febrile, 39 degrees Celsius, saturating well on room air. Blood pressure was borderline, but it's similar as her antenatal blood pressures. Clinical examination noted there's a bronchial breath sound on the right lower zone. Cardiovascular examination and neurological examination was unremarkable. Abdominal examination, soft, non-tender with a gravity uterus about 26 weeks. So the initial investigation was done in emergency department. This was the list of the results that are available. So would like to ask Dr. Hakimah, what is your differential diagnosis and further history that you would like to get from this patient?
So my differential diagnosis is hospital-acquired pneumonia or collapse consolidation or lung atelectasis, because recently she was discharged from the hospital. Further history I would like to know, I would like to further ask about any nausea, vomiting, any recent seizure before the presentation, any abdominal pain, per vaginal discharge. And then regarding the underlying epilepsy, I would like to know how was the seizure control before this, what medication she's on, and what are the triggering factor for the seizure. And because of the recent hospitalization, so I would like to know about what investigation was done, any lumbar puncture and what was the result, any history of cannulation or central venous catheterization done during the previous hospitalization, and what are the antibiotics given during that time. And regarding the obstetric history, she had history of miscarriage before, so I would like to know at what age she lost her pregnancy and whether any investigation done during that time. And also regarding the social history, whether she's working or not, she live with who at home, whether she live only with the husband or is there any other family members taking care of her.
Hakimah, I would like to ask a question. So my question to you: do you think there's any relationship between the breakthrough seizure and the fever that she's having, and how would you work out a differential diagnosis from that?
Yeah, it is possible because when patient have breakthrough seizure, there is risk of aspiration, so that one also can cause pneumonia.
So thank you, Dr. Hakimah, for the question that she's trying to, the further history and also differential diagnosis that she's trying to work out for these patients. So a bit about the further history. She's worked as a sales promoter, non-smoker, non-drinker. She stayed with the husband on and off. There's her sister and also the father will come and visit her. So regarding her diagnosis of epilepsy, she was diagnosed at 12 years old, where she presented with a seizure initially to our pediatric colleagues. So her initial EEG was done, epileptic discharge from the bilateral central parietal regions, in keeping with focal epilepsy with excessive theta activity. The MRI showed bilateral frontal lobe atrophy with no significant structural intracranial abnormality noted. Her usual fit simiology is a generalized tonic-clonic movement of the bilateral upper limb and lower limb. Occurs almost every day, about 1 to 2 times a day, which lasted for a few seconds. The usual trigger, according to her, is a lack of sleep, stress, and also tiredness. Regarding her previous second trimester miscarriage, which was happened at about 3 years ago, occurs at 22 weeks of her pregnancy. At that time, she presented with increased seizure frequency throughout the whole pregnancy, which subsequently noted absence of fetal heart rate during antenatal checkup. She was delivered and the fetus was grossly normal and the placenta HB was unremarkable. And before her current pregnancy, this is her anti-seizure medications. When she noted pregnancy, there's a change in the anti-epileptic medication. The epilim was withheld and the folic acid was added for her. And regarding her recent hospitalization, she was admitted for 18 days. She presented with multiple episodes of fitting 1 day prior to the admission. She was intubated in the emergency department upon arrival due to the status epilepticus. So total about 9 days of intubation in ICU. CT brain at that time, no focal brain parenchyma lesion or acute intracranial hemorrhage. Lumbar puncture was done. The opening pressure was high, but the investigation was within normal range. And the EEG showed abnormal EEG with epileptic discharge from both frontal central regions, more on the right than the left, with moderate diffuse disturbance. She was treated for IV antibiotic ceftriaxone for 2 weeks and acyclovir for 1 week. In the ICU, she had multiple episodes of post-ictal psychosis and also hyperactive delirium. So she was given risperidone by our psychiatric colleagues. The scan during the admission at that time about 25 weeks. The normal fetus parameters, the estimated weight is about 768 grams for the fetus. She was given IM DEXA and also magnesium sulfate for fetal lung maturations. As for her current presentation, after she discharged from the hospital, she had this fever for 3 days, associated with productive cough and also yellowish sputum with reduced oral intake. However, there's no GI loss. And at home, she noted also increased frequency of feeding episode, which is similarity as before, but this is slightly longer, lasted about 1 to 2 minutes, with uploading eyeball and during of saliva, with aborted spontaneously. Clinical examination when she arrived, as mentioned in the abstract, unremarkable except the lung finding which is suggestive of pneumonia. The investigation done, that time the x-ray was not done initially because she had multiple x-ray done during the admission for status epilepticus. So we treat based on the clinical examination. And when she first arrived, the white cell was high, the white cell was 21 with predominantly neutrophils. C-reactive protein was 16, was markedly elevated, and she have hyponatremia and also hypoalbuminemia. Mild transaminitis, and the first blood culture that came back was gram-positive cocci in cluster. And it's quite fast, the blood culture, we got the result. So from this, what is the working diagnosis for her and how do you manage this patient at this stage?
Yeah, from the history, Hakimah, yeah, would you like to first, think of what you want to do? Yeah, and as Dr. B asked, and how would you manage the patient at this stage?
So the working diagnosis now is gram-positive cocci bacteremia with HAP. And I need to rule out infective endocarditis in view of the blood culture is positive for gram-positive cocci. So how I would like to manage this patient, I would like to start antibiotics which can cover both gram-positive cocci and also for gram-negative for the HAP. So I would like to start her on IV tazocine. Because there is also hyponatremia and poor oral intake, so I would like to start IV hydration for her. Arrange for echo to look for vegetation. This patient need close monitoring in critical care unit, and also I would like to arrange for multidisciplinary team discussion to discuss about the treatment plan for her. And for the breakthrough seizure, I would like to monitor to start anti-epileptic medication, and if there is recurrent fitting, then I would like to arrange for CT brain to look for any septic emboli.
Hakimah, you are in UKM because UKM we are blessed by multidisciplinary, but to all of you medical students, this might not be the case when you are working alone in the district hospital or district physician. Now they are sending physician to district. Yeah. So what do you mean? Which multidisciplinary team that you wanna at this moment that you wanna refer to? Why?
The first team should be cardiology team, and then for the pregnancy, I should refer her to ONG team also.
Okay, thank you, Dr. Hakimah. So the working diagnosis at that time was hospital-acquired infection and also pneumonia because she had recent hospitalization for 3 weeks in ICU. Of course, when you're in ICU, they have multiple cannulations for brenula, for all types of cannulation for monitoring and also the administration of the drugs. And at the same time, the blood culture showed there's a gram-positive cocci bacteremia. So possible the infection the source may be from the lungs. And she had breakthrough seizures, which probably precipitated by the infections with underlying epilepsy. And she's pregnant at 27 weeks. So she was started on IV tazocine from emergency department before the blood culture was available. And the plan was to trace the blood culture to adjust the antibiotic based on the sensitivity. And because of poor intake, she was started on IV drip monitoring in our HCW actually. feed chart and also the input and output chart. And medication of the anti-seizure medication was continued. And the plan was to repeat the CT brain if she continued to having this fitting episode, because there's a risk of recurrent meningoencephalitis and other pathology that we need to rule out. And of course, we need to refer to our ONG colleagues for fetal assessment because she have multiple breakthrough seizures, which is a similar event that she faced during her previous pregnancy as well. So she was admitted to the ward, and unfortunately, the next day, she developed fitting episode in the ward, loaded with IV Capra, and changed the epilim to IV, and desaturated despite on oxygen supplement, and she's become more tachypnic and transferred to our GICU for further monitoring and subsequently intubated because of the respiratory distress, and was started on inotrope for the hypotensive episode. So while she was in ICU, noted there's new onset of pansystolic murmur, which was not there the day before on arrival to our emergency department. So how do you like to manage her at this stage? Because you are the on-call registrar now.
So it is confirmed infective endocarditis case. I will still continue the tazocine first because it have a good coverage for gram-positive cocci. But I will trace the blood culture and adjust the antibiotics based on the sensitivity, and also get urgent echo to look for vegetation.
So while she was in the ICU, they managed to call the lab, and verbal report is initial verbal report was suggestive of MRSA, and the subsequent formal report showed there's a confirmed MRSA with vancomycin MIC is about less than 0.5, and she was, of course, referred to cardio for echo. This is a X-ray comparison. That on the right-hand side is a previous admission X-ray, and because her current admission, there's no X-ray done initially, and the X-ray only done after she was intubated. And you can see that there's a very obvious changes in both the bilateral lower zones up to mid zones after the intubations. Probably that's explained why she desaturated while she was having breakthrough seizure and at the same time not saturating well on the oxygens. So we would like to invite Prof. Tan for the epilepsy management in pregnancy.
Good morning to Prof. Marina and everyone here today. So I'll talk about epilepsy. What is epilepsy? This is a disease of the brain defined by any of the following conditions. This lady had at least 2 unprovoked seizures occurring more than 24 hours apart. And here you can see the video of her having a seizure in the lab. All right, she has this bizarre movements, and she becomes very aggressive, confused. All right, so she fulfilled the definition of epilepsy. Or if you have 1 unprovoked seizure and a probability of further seizures, similar to the general recurrence risks after 2 unprovoked seizures. So meaning if you have 1 seizure and you have a brain abnormality, then you will also have the diagnosis of epilepsy, or you have a diagnosis of epilepsy syndrome. So why are we so concerned about women in epilepsy? As you can see, this diagram here shows the altered anti-epileptic drug metabolism in pregnant women with epilepsy. There's increased volume of distribution or serum albumin reduction. So you can see the patient's albumin levels were a bit low. Okay, there's increased renal blood flow. This is important because it will cause reduced concentration of anti-seizure drugs. Nausea and vomiting leads to reduced anti-epileptic drug absorption and induction of hepatic enzymes, leading to reduced drug concentrations. So I'll give you just a summary of management of epilepsy in women with epilepsy. So normally we will advocate contraception to avoid unplanned pregnancies. And this lady, she was not on contraception and hence she had a baby. There are problems with enzyme inducers such as those listed, or mouse enzyme inducers. And the anti-seizures also impair the efficacy of contraceptives by increased clearance of the synthetic steroids. And for contraceptions, what we advocate is IM medroxyprogesterone at 10 weekly intervals instead of the normal 3 monthly interval. And if patients are on enzyme-inducing anti-seizures, then we advocate for at least higher dose of estradiol doses, at least 50 micrograms, and for intrauterine device. So what's the effect of pregnancy on epilepsy? So there are 3 major problems in maternal, fetal, and the children. So the mom is prone to falls, blunt trauma, leading to fetal hypoxemia, asphyxia, reduce in fetal heart rate, and increased risk of gestational hypertension and preeclampsia. There are more risks of cesarean delivery. What happened to the fetus? Spontaneous abortion is one of them. Other things like congenital malformations, example, these congenital heart defects, spinal bifida, cleft lip or palate, and skeletal malformation. What about the children born to the women with epilepsy? Right, so they did a study and they look at all these children. They have low IQ, impaired cognitive development, even though they are born much later on. So this diagram shows the effects of anti-seizure medication in fetus. Okay, so we have alluded to certain drugs like phenytoin, carbamazepine. Okay, so this patient was on this sort of medications, and you can see the higher risk is with valproate. So this patient was on valproate and we had to stop it during her pregnancy. So how do we monitor during pregnancy? Of course, you have sleep deprivation, stress of carrying the baby. So we have to make sure that they have adequate sleep. Adherence to anti-seizure drugs is important. Lowest risk with lamotrigine, levetiracetam, and oxcarbazepine. Highest risk with valproate. Then we look at the seizure type and frequency, and we send to our ONG colleagues for serial growth scans for gestation babies. So normally we will also supplement with them with folic acid. Okay, so that reduces the risk of fetal malformation. Well, the best drug anyone will ask is whichever that will control the epilepsy. And we advocate for monotherapy at the lowest effective dose. So always avoid valproate whenever possible, when pregnancies are planned or in the childbearing age group. So for generalized epilepsies, if seizures cannot be controlled after with any other epileptic drug, so our aim is to keep the valproate dose as low as possible. And what about breastfeeding? All right, so a lot of us assume that we have to just stop breastfeeding, but the breast milk concentration, they do go into the breast milk, but usually in very minimal amounts. So we just have to be careful about those taking benzodiazepine, barbiturates, all right, as they can cause sedation in the babies. Okay, so sorry, this is a very small print, but you can get this about the list of medications that can be given. Okay, so this patient had status epilepticus. So what is status epilepticus? So this is her in the ICU, all right, where we're performing the EEG. Yeah? So this is defined as a seizure of continuous of 5 minutes or more, or you have electrographic seizure activity, or if the patient have recurrent seizure activity without recovery in between the seizures. So in the past, we take like half an hour for the definition of status, but with a newer classification. So if you look here, For tonic-clonic seizures, we look at 2 time points, T1 and T2. TD1 is the condition resulting either from failure of mechanisms responsible for seizure termination or from the initiation of mechanisms which lead to abnormally prolonged seizures. And T2 is when the time when it can have long-term consequences, including neuronal death, injury, alteration of the neural networks. So for this patient, for tonic-clonic seizures, you just need 5 minutes. So if the seizure occurs more than 5 minutes, then this patient already fulfilled the criteria. Okay, for focal seizures, it's a bit longer, 10 minutes. Okay, yeah. So how do we manage status epilepticus during pregnancy? It's a challenge to manage status epilepticus itself, but with pregnancy, this increases the difficulty. So as the doctors alluded to, it requires a multidisciplinary team like here. So benzodiazepine is a drug of choice. Second line agents like levetiracetam and phenytoin. For valproate, if you fail other anti-seizure drugs, so it's avoided in the first trimester of pregnancy. For refractory status epilepticus, our ICU colleagues would give propofol and midazolam. And for preeclampsia, magnesium sulfate is the first line. So termination of pregnancy, delivery is recommended in case of failure of general anesthetics, all right? So, so this is the handout. If you can like to scan in the QR code here, gives you this expert opinion on the treatment approach of epilepsy. All right, so thank you, Dr. Bay.
Thank you, Prof. Tan. So I'll continue with some of the management of the endocarditis because this is the latest guideline 2023, and also there's a 2023 guideline for the modified Duke's criteria, which I'm going to introduce later. So as you can see from this flow chart, when the patient has suspected IE, so the first thing you'd like to do is you need to get the history and also the blood cultures, which is very important, and also supplement by the imaging, which is the basic one will be the echo. And then you, based on the criteria, so you classify them into whether definite, possible, or not IE. So when definite, you need at least 2 major criteria, or 1 major, or at least 3 minor criteria, or at least 5 minor criteria. So for these patients, she's actually fulfilling 2 major criteria. So she's definite IE based on the clinical criteria. So her initial echo done in ICU. This was sent to me by my staff. So there's you can see that there's a mass here, which is attached to the posterior mitral valve. And you can see I give you on the left-hand side, there's a normal echo to compare with. So, so that is a normal appearance of the mitral valve. So when you have something attached to the mitral valve, so whether this is pre-existing patient already have some sort like a myxoma, or is a new IE that is very huge. So we proceed with the formal echo, which was done in ICU when she was intubated. And you can see that the mass is actually very huge, attached at the posterior mitral valve area. And then there is also presence of pericardial effusion as well. You can see that the pericardial effusions. So if you see this, it's actually this patient is not stable. That's why she deteriorated at that time. So this is a different view of the mitral valve. And just now we're looking at the long axis. This is looking at the short axis.
We should have asked Hakimah to interpret the echo. So, you know, Bay, given you, what differential diagnosis do you think a mass like that can be in the echo?
I think to be fair to Hakimah, I will finish the view before she interprets, because echo a bit difficult when you only see one view. So of course, as what I always tell you, when you are in emergency department, you doesn't need to do a comprehensive echo. So you just need a few views for you to decide. So for this short axis view, you also can see that there's a mass that actually attached to the mitral valve at the posterior mitral valve. And on the left-hand side, you can see there's actually small, a little bit smaller mass that's attached to the bigger mass. So these features are more of endocarditis rather than the myxoma. It's okay, it's okay. So when you have different views, so it's important to get different view because you want to know where the mass is actually attached to. So we can see that 4-chamber, 2-chamber, and 3-chamber, the mass is actually localized to the posterior mitral valve. If on the right hand side, the echo, the mass is actually at the middle, but if because of the cut of the orientation, it looks like middle, but you need other views to help you to localize to the location of the mass. So because the time constraints, so I have to finish it. I take over Hakimah. So the echo impression from the first echo is a large oscillating mass, which is actually at the P3 segment. This is an unusual site, and somehow it's actually at the base of the valve. So, and there's a small mass that attached to it. So, which possible is a vegetation, but differential will be an infected myxoma because the shape of the mass is actually quite rounded and it's multilobulated. So, it may represent the myxoma which was not causing her symptoms from beginning. And the ejection fraction was more than 50%, but the echo was done while she was on inotrope. So, it may not represent the true ejection fraction for her. And there's a pericardial effusion, otherwise there's no other features. So we proceeded with DOE for her. So DOE is a bit slightly more discomfort to do, especially when the patient is pregnant, epilepsy. So because during the DOE, she actually developed a few episodes of a fitting episode as well. So it's not easy to do because it's a stress to a patient, so it's not easy to perform. As you can see that there's a big mass actually at the posterior mitral valve. And that's causing the mitral regurgitation. This mitral regurgitation a bit eccentric, not the usual mitral regurgitation that we used to see. And in the different view, you can see that the whole mass is actually moving in and out from the atrium to the ventricle. So it's actually very mobile and very oscillating. And part of the mass is actually hypoechoic, which most likely you're going to perforate if it's untreated. And you can see that how the MR is very eccentric is I have a schematic diagram on the left side. The MR is actually hitting the mass before it turns around. So if she was not treated early, the jet will keep on hitting on the mass and the mass will just embolize. So this is just another view to show that the location of the mass. So we did a 3D for her. You can see that the mass is actually almost half of the mitral valve outlet. So when the flow of the blood will be blocked because of this mass, which is actually quite huge, which is 50% of the output of the blood from the left atrium to the left ventricle. So from overall, the size of the mass is actually very huge, 2 cm times 1.3 cm. And there is a signs of perforation that you can see from the picture on the right-hand side lower zone. Here, there is a 2 jet actually. So meaning there's the central jet will be the original cooptation. The jet after that is the perforation jet. So from this DOE, she fulfilled the criteria of endocarditis. So what makes it is endocarditis? It can be oscillating or non-oscillating cardiac mass, and the perforation that in this case that make it more of a IE than the myxoma. So these are the differential diagnosis of the cardiac masses by different location in the heart. You can have a myxoma, which is very round lobulated mass, thrombus, lymphoma, which is rare, cardiac angiosarcoma also rare. The clot is very common, but it depends on the locations. So there's a change in the Duke's criteria for IE. I think most of the textbook that previously mentioned is the previous criteria for the the IE. So there's a new change in the criteria. So the bold font is all the new changes that they make for the IE criteria. So you have major and minor. So in the microbiology, so there's a newly added, because previously we have a typical organism, so now they add on other organisms that commonly seen, and also other types of tests that we can use, like your PCR and indirect immunofluorescence test. And imaging, the newly added is your cardiac CT and also the FDG PET CT. I think we recently have one case that we shown this usefulness of this FDG PET CT. And of course, you need, if the patient have surgery, so that will be the definite criteria for the patients. And the minor criteria, there's a few changes in terms of the culture and also the methods. Criteria is still the same, 2 major or 1 major and 3 minor or 5 minor to be the definite endocarditis. So while she was in the ICU, our ONG colleague did the scan for her, which suspected IOGR and oligohydramnios. So the estimated fetal weight is about 849 grams. So now we would like to invite our Prof. Rahana for explain the obstetric management for this patient.
Thank you, Bey. I think most of the parts of the epilepsy in pregnancy has been covered by Prof. Tan. So I just touch a few areas only. Again, this is repeating pre-pregnancy. Now this patient, the management of her from the first pregnancy itself has been challenging, right? So hence that led to the unplanned pregnancy for the second one. And she had missed the most important part of the management, which is the pre-pregnancy counseling, yeah? So ideally, in a patient with epilepsy, you would want to send the patient, you would want to receive a referral from other units that she needs a pre-pregnancy counseling. So during the pre-pregnancy counseling, what is important is to highlight to the patient that during pregnancy or prior to pregnancy, probably there will be some changes in the drugs, right? So adjustment of the drugs, usually we will try to discuss it with the neurologist in regards to what is the best for her. And of course, we aim for the lowest effective daily dose of a single medication if it's possible. And the best outcome during the pregnancy is when the patient is seizure-free. So in patients with epilepsy during pregnancy, in 22.4%, they can worsen, especially in the first and third trimester. In the first trimester, it's understandable because they have hyperemesis gravidarum, isn't it? So they tend to not take their medications. In the third trimester, probably because of the increasing gestation. Some improve in 16.1%, and some stable, and majority actually are stable in 61.5%. So drug dosage needs to be increased in 50% of cases, and addition of drug is needed in 17% of cases. And so maternal effects, particularly in generalized tonic-clonic seizure, they can cause maternal physical trauma, fetal effects, teratogenicity if they are on multiple drugs, but lowest risk with lamotrigine and carbamazepine, and fetal hypoxia as well as acidosis. So status epilepticus is very rare in pregnancy. It is a medical emergency, and the risk to the fetus is compromised placental blood flow, causing fetal hypoxia. So if you do a CTG in this patient, if you have the chance, you will see changes in the heart rate of the fetus, and the outcome of the fetus, they can have intracranial hemorrhage, of course needed preterm birth or preterm delivery, intrauterine death, low birth weight or fetal growth restriction, and of course to the mother, higher risk of mortality. So for this patient, in view of the fetal growth restriction with a reduced AFR at 28 weeks, so she has been prepared for a preterm birth where we gave her dexamethasone and magnesium sulfate for fetal neuroprotection. Now the challenge that we had to deliver her at 28 weeks with FGR is of course to deliver the fetus safely, right? So you would think about hysterotomy because the lower segment is not well formed at 28 weeks, right? So it's going to be a difficult cesarean section, and ideally you want to deliver the fetus and call delivery, meaning you want to deliver the fetus in an intact sac, which is the best for the neonatologist to handle the fetus after that. Now, postpartum valve surgery, am I supposed to touch this? Huh? Okay, now, after delivery, probably she would have the cardiac surgery, right? And the problem is after, in the postpartum period, the patient has low care. So what do we do if she has to go for a cardiac surgery whereby you need a high dose of anticoagulant? So the challenge is she can go into postpartum hemorrhage, right? So what is the best duration post-delivery for a cardiac surgery? We actually do not know. There is no guideline and we only have case reports. So the first case report that I had come across, they had done a mitral valve replacement 48 hours after cesarean section and the patient's outcome was good. And another case report, they had done the mitral valve replacement 3 days after cesarean section, and also their outcome was good. So in conclusion, epilepsy in pregnancy requires multidisciplinary approach. The main aim of management is to minimize frequency of seizures with minimal drugs, and cardiac surgery in the postpartum period is high risk for PPH, but the best time for it to be done, we actually do not know. Thank you.
Thank you, Prof, for the explanation and for the management for obstetric part. So, because there's challenges in this patient, because to deliver her earlier or to wait. But the other things to consider is if you look at the serial blood cultures, she have persistent MRSA that grow from the blood cultures, despite that we started her on the vancomycin, which is therapeutic dose. So what are the choice of anti-MRSA therapy in view of this persistent MRSA bacteremia, and whether to continue this anti-MRSA antibiotic for at least 2 to 3 weeks after the surgery? What are the choice to use? Because she have this persistent MRSA, what are the drug of choice that we have? Because as you can see from the blood culture initial, she's only the only drug that's sensitive to this is only vancomycin from our lab. So we would like to invite our ID physician, Prof. Patrick, regarding the ID management.
Thanks, Dr. Bay. So the question put to us is the persistent MRSA bacteremia. And the questions we ask ourselves is why is there persistent, and when is called persistent, and what do we do about it in terms of second line options. When we get referrals for persistent, we have to go through the motions for the benefit of the medical officers. Is first, we look at whether there's an uncontrolled source. So whether it's a catheter-related bloodstream infection or a high inoculum like infective endocarditis, that may explain why the MRSA is being persistent. Second, we look at whether the therapeutic levels have been achieved. We work very closely with our pharmacist colleagues who help us a lot in calculating whether the therapeutic levels are adequate. And third, we look at something I highlighted in the yellow is minimum inhibitory concentration. So anything less than 1, so MRSA is sensitive to vancomycin for MIC less than 2. So anything less than 1 should be very, very sensitive. So you can see in these slides, throughout her stay here, she has a very sensitive strain. The MIC is always below 0.5. So technically, she should work, the vancomycin should work. Okay. So first, we look whether the levels are adequate or not. So here we work with our pharmacists who will help us calculate the area under the curve. So this is area under curve under MIC ratio should be around 4 to 600. So as you have seen in the slides, the levels are adequate already. So that one problem settled. Okay. Second, we look at the MIC. As you have seen in the slide, the MIC is always 0.5 and above. So if your MIC is around the border breakpoints, you can see your success rate is around 40%. But if your MIC is less than 1, you should have 90% over success rate. So her MIC is always been 0.5. So regardless of that, the question is the MRSA is persistent, when one should act. to use second-line therapy or expensive combination therapy. So if you look at persistence of MRSA here, and here is the percentage of survival. Here, if you look at the days of the MRSA is being positive, anything 1 to 3 days, you can see the mortality is coming down. Okay, initially the first 3 days is similar. Okay, but once you start passing the 4 to 6 days, you can see the clinical success, patient survival rate comes down. Okay, sorry, cannot see. All right. And then in the third slide, you can see once it passed 7 days, that means the MRSA is longer than 7 days, you can see the mortality, it's much poorer. So most guidelines would recommend anywhere between 5 to 7 days, you should try to use experimental or combinations therapy of some sort. Okay. So in this systemic review of 3 randomized controlled trials and 12 retrospective studies of 2,000 over patients, so what does combination therapy, does it even help or does it add value to the therapy? That's been shown to reduce clinical failure, bacteremia recurrence, and in this case, we want to render this patient culture negative. So the first job of infectious disease is to render the blood culture sterile. That's the most important thing. So at least in this case, combination therapy has shown to reduce and shorten the duration of bacteremia. So what we did, we used a very expensive class. It's a cyclic lipopeptide drug called daptomycin. It's an anti-MRSA drugs. And we use a 5th generation cephalosporin, very broad spectrum with MRSA coverage ceftaroline. Okay, so we gave this combination for 2 weeks. So immediately 2-3 days after this combination therapy, you can see the blood culture is sterilized. Okay, this is what we call sort of a nuclear option for these patients who have persistent MRSA bacteremia, and she remained so throughout her remaining stay in the hospital, right? So this combination itself, it cost the hospital around 10,000 Malaysian ringgit itself. So normally what we do is once the patient is sterile, usually around 1 week, we go back to our monotherapy, vancomycin, because our job is to render the patient sterile. And the question is whether once the patient is negative, if you go back to vancomycin, will it relapse? And very, very rarely we see that in clinical practice. So this patient will prolong it a bit longer than 1 week, up to 2 weeks. And then we switched her back to vancomycin on the 31st of October, and she remained again negative throughout her stay. And then the mitral valve replacements was started on the 16th of November. Then the question comes that she wants to go home, and there's a question about oral option in infective endocarditis. So in this patient, we decided to actually use linezolid and fusidic acid as an oral option for her, because thinking that if you were to use a rifampicin-based therapy, there will be a lot of drug-drug interaction with warfarin. That means we have to use a very high dose warfarin, because rifampicin is a P40 inducer of the enzymes, and you have to use high dose of warfarin. So where we get evidence of using oral options, you can see here, these are some of the options available from the landmark trial, POET trial, about IVOS, intravenous to oral option therapy for infective endocarditis. Okay, that was published in 2019. So does it work? Using oral option for infective endocarditis, okay, people might be afraid of using, but 6 months down the studies, the trials have shown no difference in all-cause mortality, unplanned cardiac surgery, embolic events, or most importantly, relapse of bacteremia. So it's a viable option for her. The last question we would like to answer is the duration of antibiotics post mitral valve surgery. So patients with gram-positive have higher risk of infective relapse of infective endocarditis. And the question to ask is, what's going to be the outcome of the mitral valve replacement in terms of whether the valves are still positive or not. So if the valves just remain positive, usually we advocate 6 weeks of antibiotic following valve surgery, only if the cultures are positive. So you can do IVOS for patients provided you have blood culture that is sterile, CRP a drop of 25%, white cells is below 15, and echo shows no evidence of any abscesses. Okay, with that I thank you.
Thank you, Prof. Patrick. So for this patient, she was given the so-called salvage therapy for the anti-MRSA, and then she managed to achieve culture clearance. And then here they come. So while in the ICU, so she developed this embolic event, so which was not there on her initial admissions. As you can see that from the sole and also the palm and also the nails, she have this sign of stigmata of IE. So for the benefit of the medical students, so I just list out some of the signs that to look for in the IE. So you have a sphincter hemorrhage. Osler is painful. Janeway is not tender. And then these are the example. And rarely nowadays you can see clubbing already. Most of the patients get treatment earlier. And sometimes the emboli can be go to the distal part of the peripheries. Can cause the fingers and also the toes to be gangrene. These are the example. Other things to look for is a raw spot. Things can cause is a hematuria and septic emboli to other part of the body, such as a lung if the IE is on the right side, and abdominal embolization can cause splenic abscess and also infarct. Okay, these are the example of the raw spot. The lower part is the raw spot that patient, not this patient. Those that treated with IE, they can see the resolution of the raw spot. The complication of this, sometimes, if you remember the first bit, when she first arrived, there's no murmur. The murmur developed later. So meaning the perforation causing the patient to be deteriorated after that. So some of them can develop heart failure and AV block, heart block as well. It can emboli to the brain, can cause stroke-like and also intracranial bleed, and cause confusion, drowsiness. Sometimes can increase seizures. So for this patient, because of all these events, so we have MDT discussion. So we involve multiple teams, and as well as the patient and also the family. So the conclusion was for planned early premature delivery at about 30 weeks via elective cesarean section in view of IUGR and also failed medical therapy with frequent breakthrough seizures, and also for early WAF surgery after the postpartum because of already had embolic events. However, things never follow the plan. So she had premature contraction pain in labor the day before, 1 day before the planned cesarean section. So she delivered actually at midnight, I think about 1 a.m. So it's a baby girl, 1.15 kilo, require intubation for prematurity with ARDS. And the patient itself, herself was extubated on day 2 after delivery and weaned off the inotropic support. So because of the embolic event, so the concern was if we do MVR early, what will cause her to have more harm or benefit? So we have a discussion again and decided to do the MVR at 2 weeks because there's no guideline which one to follow. So this is the things that we need to do as a consensus of all the teams. So next, I would like to invite our cardiothoracic team, Mr. Hisham, for the explanation.
Assalamualaikum, a very good morning. Salam Watan University Watan, Salam Madani. Thank you so much for inviting me. Right, as I said before by Dr. B and all the panels, it is a complicated case, all right, needing MDTs and after MDTs and after MDTs. All right, we have epilepsy, and then patient is pregnant, and whatnot, all those septic embolies just burst from the IE, and now, right, down, okay, right. Okay, right. This is a CPG by KKM. I think most of us recognize this, and probably for the medical students, probably very good idea to download this for the sake for your exam. Right, and what is the indication for surgery? This is indication for surgery is clear cut. You have to do a surgery for IE and very bad emboli. Okay, this is, can I scroll this? All right, okay, no. Okay, the clinical condition, the patient having cardiogenic shock, pulmonary edema or large vegetation more than 1 centimeter. Of course, this patient have more than 1 centimeter of vegetation, and patient has a persistent infection more than 5 to 7 days of initiating antimicrobial. So there's directly indication for the surgery. What is another one is what is the timing for surgery? Okay, all right. This is the guideline showing that there's emergency if patient having shock, urgent within 3 to 4 days, early 1 to 2 weeks. All right. So bear in mind that this is a guideline. Then we have to cater the guidelines to patient. All right. Now the patient's having epilepsies, and also patients just deliver. Okay. All right. Next. And this is another chart showing the timing for surgery. When patient heart failure, of course, definitely going to be as soon as possible. Uncontrolled infection. I will talk this one later on, and then also high risk emboli. Remind you that the patient has a large vegetation with hypodense areas and probably pus inside there, all right, with active infection, with MRSA, persistent MRSA, and this is not going to be a high risk surgery. Going back to an uncontrolled infection, this is another thing that concerns surgery, cardiac surgery, especially so in aortic position, not mitral aortic position. Why? If there is uncontrolled infection, there is a high association with any pericardial abscess or tubal abscess or area that will be going to be very, very friable for us to suture. All right, it's just like suturing on a taufufa. All right, it's not going to take. Cannot suture, cannot place, so that the valve that we're going to replace is going to be rock, and also going to be leakage. So this is one of the things that going to be a bit difficult as to when to do the surgery. Is either to settle about the infection first, or do the surgery as soon as possible. But then we have a few MDTs again. This is a thing that we need to do as soon as possible because of all the clinical signs have been shown. Oops, sorry. Okay, as Prof. said, this is a very rare case, probably one in 10,000. There is no even a short series of case series in the literature. It's all short case reports sahaja. So as to how to manage, but they really advocate MDTs. Okay, all come together and to give a very good concession to how to manage the patient, when to do surgery, how to manage the pregnancy and whatnot. But I think this is the first, probably, a complex which includes epilepsy, pregnant, IE. So three come together, probably is going to be a very, very most cited case report, I guess, right? The first one in the world, probably, right? Okay, this is for the benefit of medical student. Why did Prof. Hana said about postpartum hemorrhage and whatnot? Okay, just a brief. I'll tell you about what is cardiac surgery about, especially in mitral valve replacement. During the surgery, that we need to stop the heart, put the heart to sleep. All right. In doing so, we cannulate the IVC and SVC into the pump. All right. So the blood going to the pump called cardiopulmonary bypass machine, and also after oxygenated the pump, the blood will go through back to the patient into the aorta. We cannulate the aorta. So bypass the function of the heart and bypass the function of the lungs. Okay. In doing so, we need to have a very, very high heparin to be infused to the patient because we do not want a clot inside the pump. So very, very high. ACT probably normal 113, going to be 4 to 5 times higher, probably 400 to 500 ACT. So in doing so, we can rest the heart, and also we can do the surgery. We did a placement of a mechanical valve. I will tell you about why a mechanical valve later on. But the thing is, patient has a very raw wound. Okay, a very raw wound. That's really going to be high risk of postpartum hemorrhage. So this is a thing that we must highlight to the patient if there is a bleeding during the surgery, during the high heparin. So what to do? There's a possibility that we have to reopen the uterine again with a lot of salvage or even hysterectomy. Okay. Another question is why mechanical valve? Okay, bear in mind that mechanical valve has longevity about 20-25 years. Okay, compared to the tissue valve, and tissue valve is really easy to be classified, especially in infective state of patient. All right, but with mechanical valve, patient have to be on warfarin after surgery. Okay, two things that was important. Number one is that patient on warfarin, patient is young, patient wants another baby. Okay, there's a possibility of 4%, nearly 7% of patient having abnormal baby during first trimester if patient on warfarin. Okay, number two, patient has status epilepticus. When patient are given on warfarin, so patient tend to fall, bang her head and whatnot, have hemorrhage. So two things very important here when we put on mechanical valve. Why is going to be long, 25 years, and going again after the first surgery to replace another valve is going to be increased in morbidity and mortality. So that's why we choose the mechanical valve. So this is the real photo of the patient. If you can see, the vegetation is just stuck to the posterior wall and posterior wall, right? And there's a small at the down there. Okay, you're going to read about that. So post-operatively in CICU, patient is okay, very good and very well, and gone back to the wards. I think he developed very short epilepsy after the surgery, I guess, but everything's well controlled for her. And then she was discharged very well. Thank you so much.
Thank you, Mr. Sham. So as you can see, there's the challenges in in this case because a lot of factors to consider. We want to do the surgery in the postpartum periods. So from the surgery, when you have the mitral valve replacement, of course we need to send the tissue for HPE to confirm our initial diagnosis. As you remember, when we label the patient as endocarditis differential is an infected myxoma. So we would like to invite our pathology colleague for Dr. Tang he was representing Dr. Faizal for this HPE.
Good morning to professors, consultants, specialists, colleagues, and also medical students. So I will be representing Dr. Faizal Rina, my specialist, in presenting a few of the histology slides for this patient. So macroscopically, we receive multiple fragments of brownish tissues and an intact mitral valve. The mitral valve consists of anterior and posterior valve, with the anterior valve measuring about 20 × 25 × 3 millimeters, and posterior valve measuring 14 × 6 × 3 millimeters. And the anterior valve shows focal thickening and some yellowish calcifications. And the largest brownish fragments measures about 15 × 16 × 10 millimeters and firm and dark brownish color. So this is the first picture. It's a section from the valve fragments from low magnification view. And as you roam around the sections, we can see this picture where focal areas of adipocytic metaplasia. In another term, there are fat cells infiltration seen. And as we zoom around again, we'll see some sections containing a myxoid degeneration, which is the bluish area that we see in this picture. So this is the area of interest that we're looking for. In this view, we can see a clump of fibrin deposition, which is most prominent in the upper part of the picture, which is a pinkish, highly pinkish color. And then the granulation tissue, which also most prominent at the upper right of the picture, which is a lot of blood vessels and red blood cells. And in the middle, there is a band of dark blue or purple dots-like thingy that will be neutrophils, apoptotic bodies, and other inflammatory cells. As you go higher magnification view, this is the area where I mentioned just now. There are a lot of neutrophils, extravascular red blood cells, fibrin exudates, and also apoptotic bodies. So again, we do a gram stain, and we're able to find these clusters. In here, it's not very clear, but under the microscope, we can see cocci, clusters of cocci, which is gram indeterminate. Why we say indeterminate? Because the typical one, gram negative rod should look pink color, and gram positive should either look blue or dark purple. But in this case, it's none of them, so we put as indeterminate. So our diagnosis is consistent with infective endocarditis, and gram stain is indeterminate, which probably due to previous antibiotic treatment. That is all from me. Thank you very much.
Thank you, Dr. Tang. So after the patient was started on the salvage therapy, MT-MRSA, then subsequently we switched back to IV vancomycin and managed to do the surgery, and surgery is uneventful. So the outcome for this case is she actually discharged from the ward after about 1 month stay in the ward, more than 1 month stay in the ward after the total 4 weeks of antibiotics from the culture clearance. And there's no more positive culture subsequently. And she was switched to oral combination because she insisted want to go home because already more than so long she stay in the ward. So ID have no choice to change to this oral combination for her. And while follow up in the clinic, she remained asymptomatic, achieved good INR target, and the baby was growing well, no developmental issues so far. So this will be the happy ending for her, as finally she got 1 baby. So if you look at the phases of antibiotic for the IE treatment, so of course when the patient first came in, you started with IV, and then you try to remove the source of infections. As for this case, a bit challenging because she's pregnant, so and also the persistent bacteremia, so she need to be delayed a bit for the clearance of the IE, and then subsequently she was changed to oral combinations. So in summary, you need an endocarditis team, which is we still don't have this team yet in our hospital. So in overseas, we have this endocarditis team. When the patient suspected IE, all the team will be on board to decide on the best treatment for the patients. And then you look for the complication. If there's no complication, you continue antibiotic and you plan the surgery. If you have complication, need to plan the surgery early. And of course, need to prevent the patient from develop another IE, so the hygiene, especially the dental hygiene. Most of the patients have this problem of the source is from the dental caries. This article is just published last month, so it's June. So it's not a guideline. It's just to explain what are the things that we have, the challenges and also the outcomes and the strategies in the management. As all the things is mentioned here, which is all happen in our patients. So in the end, I would like to thanks all the teams that involved in this treatment for the patients. I know some of the team are unable to invite because of the time constraint, because I cannot invite everyone. So I need to limit to some of the teams only, just for benefit of the learning. All right, thank you everyone.
So thank you, Dr. Bay. Thank you everyone for helping us in managing the case. This really shows the strength of UKM, which is multidisciplinary.